This is the mic test. Can you all hear me? Can you please put in the chat or indicate in the chat if you do? Thank you. Good day to everyone. We have a very good representation of countries and nationalities today, and it is exciting to welcome all of you. My name is Dr. Tom Madayag, who will serve as your lecturer in today's webinar. I am a consulting faculty for MedPro U and a full-time professor at Broward College here in Florida. I am an adult gerontologic nurse practitioner. I have been teaching ECG to paramedics, nurses, and physicians for over 30 years. I just wanted to do some housekeeping first. And the first thing is that I wanted to inform you that a copy of the PowerPoint used in this webinar is going to be available to you in the Canvas modules page. The video recording of this webinar will be in the Canvas modules page several hours after the conclusion of this presentation. It will also be in Dr. Tom's YouTube channel. In order for you to ask questions, there are two ways to ask a question. One is to write the question in the chat box. I will be answering them at a scheduled interval. Or you could raise your hand, and once recognized, you could unmute your microphone. Some of you were also commenting the last time that you weren't able to, or you wish that the slides were bigger. Well, I want you to know that there's nothing that I can do to make it bigger, but there's something that you could do to make it in your end to zoom it. Under the view options, you could toggle the choices and you can zoom a particular slide. Okay? At the same token, the volume of my voice cannot be maximized either. From this end, it has to be maximized or controlled from your end. So with that in mind, let's go ahead and go forward. So why are we here today? Well, we are here hopefully to accomplish two objectives listed on the slide. These objectives were set because an expectation of the ACS, or acute coronary syndrome protocol here in the United States, is that a healthcare professional must obtain and interpret the 12-lead ECG on a patient within 10 minutes of presentation. It is imperative that as a practicing nurse here in the United States, you must be proficient in identifying a type of MI called STEMI, or STEMI, and early identification of the presence of this type of MI will save cardiac muscle. Distinguishing patients with unstable angina from those with acute MI may be impossible during the initial presentation because their signs and ECG findings may be identical. Therefore, it is necessary to have a combination of ECG findings, history, cardiac biomarkers, and other test results to confirm the diagnosis of myocardial infarction. So, hold on one moment. So most, if not all of you, have seen a 12-lead ECG. It is called a 12-lead ECG because it offers us 12 different views of the heart. It is obvious that 12 different views offers more advantages than a single view. Hence, we use a 12-lead ECG to diagnose the presence of myocardial infarction. I must emphasize that you should never interpret the presence of myocardial infarction just because of an abnormality in one view or one lead. The changes in one lead should be corroborated by other related leads. Now, the typical layout of the ECG includes the following. There are 6 limb leads, as you could see over here: lead 1, lead 2, lead 3, AVR, AVL, and AVF. They're referred to as limb leads because these are leads connected to the arms and the legs. They are designated again as leads 1, lead 2, lead 3, AVR, AVL, and AVF. AVR stands for augmented vector right. AVL stands for augmented vector left. And AVF stands for augmented vector foot. There are also 6 chest leads, also referred to as V leads, and they are V1 to V6. By the way, each lead, as you could see from this distance to this distance right over here, and let me just, so from here to here is going to be a 2.5-second view of the heart's activity. So each one of these segments are 2.5 seconds. So it gives you a snippet or a sample of a 2.5-second strip representing each lead. The total sample time from here all the way to the end is 10 seconds. At the bottom of the paper, right over here, there will always be one lead or 2 leads that has a continuous rhythm strip. In this example, there is one lead, lead 2, and this rhythm strip allows you, therefore, to interpret the underlying rhythm that is present, like in this example, which is a normal sinus rhythm. At the beginning or the end of a 12-lead ECG tracing is a mark that is known as a standardization mark. Now, sometimes it's at the beginning, sometimes it may be at the end. This mark is automatically inscribed by the machine. A normal standard, or like over here, this is a normal standard, consists of 10 small boxes or 10 millimeters going up, which equals to 1 millivolt. Okay, so as you could see over here, and I'm going to zoom that in, you notice this mark right over here. As you could see, if you count the number of small boxes, there are 10 boxes going up and 5 boxes across. Is that clear so far? All right. If this is a standard mark, what it means is that the machine did not adjust the height or the width of the waveforms and complexes. They're recorded as they are. Now, there are times, however, when the machine needs to make adjustments. For example, if the machine needs to make an adjustment because the waveforms are too large. If they're too large, they're going to cover the entire paper, and therefore you're not going to be able to see it. And thus, the machine will automatically decrease the amplitudes or the sizes of the waveforms. When it does that, then it inscribes this particular mark. So what do you notice about this particular mark? It is now only 5 boxes in height. Can you see it? It is only now 5 boxes in height. So this means to say that what you're seeing is actually 1/2 of the actual ECG amplitude. Now, there's also the opposite. Sometimes the ECG complexes might be too small, and therefore it would be very difficult for you to read. And thus, the machine would have to amplify it. And so when it does, it's now going to say it's going to be a double standard. So in this double standard, as you could see, it's no longer 10 boxes going up, but 20 boxes going up. All right. So that is what this standardization mark means. Is there any question about the standardization mark? All right. So what are the instances wherein the machine needs to decrease the amplitude? Well, an example of that is anytime you have left ventricular hypertrophy. When you have left ventricular hypertrophy, your QRS complexes will be too tall, and therefore the machine has to decrease that amplitude in order for you to be able to read it. So what are the instances wherein the machine has to multiply or to increase the amplitude of the QRS complexes? Well, in instances wherein the waveforms are too small, would include instances wherein the patient is obese. There is a larger distance for the electrical complex to travel from the heart itself to the chest, or it could be as a result of a patient having an effusion, for example, either a pleural effusion or a pericardial effusion. So small amplitudes are representations of those kinds of pathology. Here is another view of a typical 12-lead tracing. Now, this is, what is this sign again? What is this? This is the standardization mark. And is it a normal standard, half standard, or is it a double standard? Normal standard. And the reason we know that it's normal is because there's only 10 boxes going up. Okay, so what I wanted to point out to you now is that as you could see over here, there are marks right here. Now, sometimes people will confuse these as pacemaker marks. They're not. They're the dividing points between leads. So if you could see here, lead 1 starts from here and ends over there. And AVR begins over here and ends over there. So all these marks are actually markers for the beginning and ending of each lead. All right. Do not confuse that as being pacemaker marks. And as I said, the distance from here to here is going to be 2.5 seconds. 2.5 seconds. So you have snippets of 2.5 seconds for each lead. Okay? All right, moving forward. So now let us talk about myocardial infarction. We all know what it is, but I just want to touch on the two types of myocardial infarction. The two types of myocardial infarction are called non-stemi, and the other one is STEMI. And that's the one that we're going to be talking about today. Now, you might ask, which one is worse? Well, the bottom line is that both are just as bad. STEMI, however, is seen as more of an immediate emergency because there is a known total occlusion of a heart vessel that needs opening up urgently. However, in terms of long-term outcomes, they have equal implications. So you now have a blank screen in front of you. And what I'm going to do is to illustrate these types of myocardial infarction. So supposing now that this is a muscle mass of the left ventricle, if the damage because of an occlusion of an artery causes damage from the endocardial layer to the epicardial layer, so there's full thickness damage of the muscles, this results in a type of MI called STEMI. However, there's another kind of MI wherein the damage actually is just partial. So it might just be subendocardial, it could be subepicardial, or it could be right in the middle of the myocardial layer. This results in what is known as non-STEMI. Okay? So those are some of the differences between STEMI and non-STEMI. As you could see, in non-STEMI, the ECG changes might include ST depression, T-wave inversion, or it could actually be without any unusual happenings, or it could be normal. However, in an ST elevation MI, there are going to be changes that are going to be characteristic for it to be identified as such. And it might include tall T waves, ST elevation, and the other one is a new onset of a left bundle branch block. We are now going to be interested in, therefore, how to diagnose STEMI based on a 12-lead ECG. So a manifestation of STEMI, as the term denotes, is an elevation of the ST segment. This is just an illustration of the different waveforms, intervals, and segments. We will focus on different areas to help us diagnose the presence of STEMI. So the first thing is the baseline. As you could see, the straight lines in the electrocardiogram, as I am pointing at now. Let me just, right over here, the flat lines are what is known as the baseline. Okay, so the baseline should be straight all throughout. The second thing is the ST segment. The ST segment should lie in the same plane as the baseline. So always make sure to remember that the baseline always begins with the PR segment, not the PR interval, but the PR segment right over here. So this is the beginning of the baseline. So if you put a ruler right over here, you should have a straight line all the way to the end of the T. So the ST segment, which is the connection of the S wave to the T wave, is going to be supposedly at the same plane as the baseline or the PR segment. So if you have deviations, there's going to be either a deviation going up or going down. If it is going down, we call that a ST depression. And if it's going up, we call that an ST elevation. So on the right-hand side of the screen, as you could see, if I'm now drawing my baseline, what do you see the ST segment to be? Is it normal? Is it depressed? Or is it elevated? Very good. It is elevated. So from now on, though, we're going to say that in order to claim that a patient has SEMI, it has to be a pathologic ST segment elevation. In other words, just because an ST segment is elevated does not mean to say that it is diagnostic of MI. It has to be significant. And the definition of significant is 2 millimeters or more. So in this particular example, could you tell me, and I'm going to zoom it so that you could see it well, how much ST elevation do we have over here? How many millimeters or how many small boxes is the ST elevation? So if you were to count, you would begin from this baseline right here, right? And you would say 1, 2, 3, 4, 5, 6, around 6 millimeters of ST segment elevation. This is going to be a significant ST segment elevation. All right. So sometimes we also are confused about where the ST is located. Well, the beginning of the ST segment is known as the J point. So let me emphasize that. The beginning of the J point, of the ST segment, is the J point. So notice in this particular part of the slide, right over here, this is where the J point is. Now, the rule here is that the J point must be located at the same plane as the baseline. Note on the right side of the slide that there are deviations of the ST segment. The first shows an ST elevation with an ST takeoff from the baseline, measured as how many boxes? 4 boxes or 4 millimeters. So this is a significant ST elevation. The other pattern illustrates ST segment depression. And we could measure that, and it is approximately 3 small boxes or 3 millimeters. So again, in general, ST elevation, significant ST elevation, is a sign of ST elevation MI, and ST depression is a sign of myocardial ischemia. Now, defining it further, we're going to say that we're going to follow this, that ST elevations, in order to be significant, has got to be 2 millimeters or more. And if it is going to be a depression of 1 millimeter, then it's going to be a sign of myocardial ischemia. So there are three markers of myocardial infarction: elevated ST segments. If it is 1 millimeter in the limb leads or 2 millimeters in the chest leads, these are now going to be markers of the diagnosis of myocardial infarction. And in addition to this, it must be present in 2 leads. So let me emphasize again by writing over here what the criteria is. So there has got to be ST elevation in order to diagnose STEMI. And this ST elevation should be 1 millimeter or more in the limb leads or 2 millimeters in the V leads. Okay, so that's always the rule, that there's going to be at least 1 millimeter in the limb leads or more, and that it has to be 2 millimeters or more in the V leads. It's more in the V leads because the heart is closer to the chest, and therefore that number has got to be 2. Okay, and in addition to that, what else did we say? It must appear in at least 2 contiguous leads. 2 leads. So if you only have an ST elevation in 1 lead, that does not count. It has to be 2 leads that are related. And I will define what relation is later on. Okay?
Paulo. Paulo. Ni, taray-taray. Paulo.
All right, I muted everyone. I'm sorry about that. All right, I wanted to ask if you have any questions at this point. How much ST segment elevation is there in this slide? Is it significant or is it benign? And the spelling of benign was misspelled. All right. So most of you, I think, got the correct answer. There is a 2 millimeter elevation, ST segment elevation. And therefore, because it is 2 millimeters, we said that any 2 millimeter ST segment elevation is benign. Okay. But the definition of significant is 1 millimeter in the limb leads or 2 millimeters in the V leads. And so therefore, even if this is a limb lead or a V lead, it is going to be significant. So the correct response, therefore, is that there is going to be an ST segment elevation of 2 millimeters, and this is significant. Okay? Our ST segment elevations always a sign of pathology. True or false? Okay, the correct answer is false. And this is how you responded, right? So remember that ST segment elevations may be benign, but they could also be a sign of something else. And that's something else I'm referring to, for example, is pericarditis. It could cause ST segment elevations, but there are distinct differences in the way ST segment elevations are in pericarditis. It is also, there's also a condition known as early repolarization, which is a normal variant that would cause ST segment elevation and others. However, our discussion today focuses on STEMI as the cause of ST segment elevation. Now, having laid the foundation for the diagnosis of myocardial infarction, as far as the ECG is concerned, we're now going to talk about the different views of the heart. ECG changes of ischemia or infarction are considered significant if they are viewed in two or more anatomically contiguous leads. What is this word anatomically contiguous leads mean? To better understand the term contiguous leads, look at the color-coded image on the right side of the slide. As you could see, there's blue, yellow, red, and so on. Okay? The colors were added so that you can quickly see the areas of the heart viewed by the same leads. For example, leads 2, 3, and AVF appear the same color in the table because they view the inferior wall of the left ventricle. Now, if you're taking notes, I'd like for you to take this note, therefore, that leads 2, 3, and AVF are leads that view the inferior wall of the left ventricle. So as you could see over here, and I'm now going to write right over here is going to be the inferior aspect of the left ventricle. Now, there's something interesting about the inferior aspect of the left ventricle because actually it lies on the diaphragm. And that is the reason why this is sometimes referred to as the diaphragmatic portion of the heart. Okay? So, in order to diagnose or find out if there has been an inferior wall MI, there has got to be changes in two of these three leads. So you could have an ST elevation in 2, 3, and AVF, or you could also have ST elevation in lead 2 and 3, or 3 and F, or 2 and F, and any combination thereof. The rule is that you must have 2 of those relatives. You got it? So a significant ST elevation in 2 of these leads, therefore, will meet the criteria for infarction. What again this means is that if there is a significant ST elevation in 2 and in lead 3, but not in AVF, it still meets the criteria for infarction since it meets the 2 related or contiguous lead requirement. Okay? Now, let's say now that I have an ST elevation in lead 2 and lead V3. Do we have an MI? Again, if I have an ST elevation in lead 2 and an ST elevation in V3, do we have an MI? And the answer to that is no, they're not relatives. Okay? So in order to diagnose, again, STEMI, it must have changes of ST elevation in 2 related leads. And the relatives are leads 2, 3, and AVF, which is going to be representative of the inferior wall aspect of the left ventricle. All right, so the lateral views of the heart are going to be seen by 4 leads. Leads 1, AVL, V5, and V6. And as you could see over here in blue, right over here, is the lateral portion of the heart. And this particular portion of the heart could either be a high one, so this is detected by lead 1 and lead AVL, and the lower one, V5 and V6. So again, all you have to have in order to diagnose a lateral wall MI is any 2 of these 4 leads. Understood? The anterior aspect of the heart, anterior, is viewed by lead V3 and V4. And as you could see over here in red, is going to be the anterior portion of the heart. Right over here is the anterior portion of the heart. And it is going to be viewed by V3 and V4. If I have an ST elevation in V3, but nothing else, can I diagnose an anterior wall MI? No, okay? You must have 2 contiguous leads. All right, so that is going to be the anterior aspect of the heart. Let me just mute again. Please make sure that you mute yourself. And lastly, the septal portion of the heart is seen by V1 and V2. So any changes in V1 and V2 is going to be diagnostic of a septal wall MI here in green. This is the particular area that is going to be affected when you have a septal infarction. So because this region is very much adherent to one another, so usually when you have an anterior wall MI, it could be accompanied by a septal wall MI. And it could also be accompanied by a lateral wall MI. Okay? And the other relationship is that this inferior wall MI is very close to the right ventricle. It actually is right over here, the right ventricle. And therefore, when you have an inferior wall MI, you might also have a right ventricular wall MI. So always think about those relationships because of their proximity to one another. All right, this slide illustrates the relationship of the segment of the heart that is occluded and the corresponding artery that is the culprit. Thus, when a patient is diagnosed to have an inferior wall MI, the artery that is occluded is going to be the right coronary artery. If the anterior portion of the heart is involved, then the left coronary artery is going to be the culprit. And for the circumflex coronary artery, it's going to be the lateral wall of the heart. So as you could see, the right coronary artery going to the right feeds majority of the lateral portion of the heart. So if you have a lateral wall MI right over here, the arterial supply the arterial supply is going to be the right coronary artery. Okay. If you have a right here, an anterior wall MI, then it's most likely that the artery that is involved is the left anterior descending coronary artery. And then, of course, if it is going to be the circumflex coronary artery right here, this is the one that feeds the lateral portion of the heart. Okay, so a patient presents with an inferior wall MI. Which coronary artery is most likely involved? Can you put your answers in the chat box? The right coronary artery. If the patient has a lateral wall MI, which artery is most likely involved? The circumflex coronary artery. Very good. And if you have a septal wall MI, which artery is going to be involved? The left anterior descending coronary artery. Okay, very good. So let's move forward. Let's now look at the various segments of infarction, beginning with the inferior wall. This area is also called, as I said earlier, the diaphragmatic wall, and thus inferior wall MI or diaphragmatic wall MI can be used interchangeably. In most individuals, the inferior wall is supplied by the posterior descending coronary artery, which is a branch of the right coronary artery. The anatomical proximity of the segment of this ventricle to the diaphragm explains why patients with this type of MI typically present with increased parasympathetic or vagal activity. Notice that patients with inferior wall MIs, you frequently see them vomiting quite a whole lot, or they might have uncontrolled hiccups. For those of you who work in the emergency room, an accident, you know that when a patient comes in with signs of MI and they're vomiting quite a whole lot, this points to the possibility that this is an inferior wall MI. It could also be uncontrolled hiccups. So because of the proximity of this segment right over here, as I said, to the diaphragm of the patient. Bless you. Mute again. Okay. Sorry, I just had to mute first of all. So the diagnoses of inferior wall MI are significant ST elevations in 2, lead 3, and AVF. Remember that any 2 combinations is acceptable. It is not necessary to have all 3 leads demonstrating ST segment elevation. So let's take an example. So whenever you are looking at a 12-lead ECG, what I'd like for you to do now is to do it systematically and say, okay, I'm going to find the baseline. And the baseline is always at the PR segment. This is the baseline, this is the baseline, and this is the baseline, and so on and so forth. Okay? So what you're going to do is you're now going to say, okay, in lead 1, is the SC normal? Is it elevated? Or is it depressed? So I'm now going to ask you that question. Is the SC segment in lead 1, elevated, normal, or depressed? It is depressed. Okay, so we're going to say or label this D, okay, for depressed. Let's go to lead 2. Is the ST in lead 2 elevated, depressed, or normal? Okay, so you say that it is elevated. And let's go to lead 3. Is the ST segment in lead 3 normal, elevated, or depressed? While it is elevated. Now, for the purposes of diagnosing MI, we're not going to look at AVR, okay? So this is only useful for several reasons for other than STEMI. So we don't look at AVR when we're diagnosing MI. So let's go to AVL. Is AVL depressed, elevated, or normal? Okay, so it's depressed. How about AVF? Okay, it's elevated. And V1? V1? Okay, depressed. And V2? Depressed. And V3? I think V3 is normal. Okay. And how about V4? Okay. So again, you can zoom in or I can zoom in for you. All right. So there's a lot of complaints in the evaluation saying, I can't see the slides, they're too small. Well, there's nothing that I can do. You have to do it from your end. Again, from the view options, you can zoom it. All right. Okay, V4, what is V4? It's slightly elevated, but guess what? It is not more than 2 millimeters. Because you remember in the V leads, they have to be 2 millimeters. So we're just going to put a question mark over here because that's elevated, but it's not significant. It's the same thing over here in V5. It's also the same thing as V6. So they look elevated, but they are not significant ST elevations. Okay. So after we have done that, we're now going to say, okay, lead 1, lead 2, lead 3, and AVF are elevated. And we say, okay, are they related? Are these contiguous? And contiguous leads are going to be 2, 3, and AVF, representing the inferior wall. And therefore, we can safely say that this 12-lead ECG is positive for an inferior wall STEMI. Okay? All right. Let's move further. Because the inferior wall is very proximate to the right ventricle, as illustrated in this slide. Here's the right ventricular wall right here. 97% of them, to be exact, is going to be the occurrence of right ventricular infarctions in the presence of inferior wall MI. This is because they are usually caused by an obstruction in the right coronary artery, which also supplies the inferior wall. Make it a habit, therefore, to check for right ventricular infarction whenever you diagnose inferior wall MI. It should be routine to perform a right-sided chest lead application also to ensure that you can identify a right ventricular infarction. Right ventricular infarction is usually accompanied by 3 main symptoms, and they are hypotension, jugular vein distension, but there is clear breath sounds. The right ventricle in this particular instance may lose its ability to pump blood into the pulmonary circuit, which causes the triad of symptoms, as I indicated, of hypotension, jugular vein distension, but clear breath sounds. This is the reason that in this type of myocardial infarction, nitroglycerin should never be given. Let me repeat that. In the presence of a right ventricular infarction, you must not give nitroglycerin. It is avoided because of the already compromised and decreased preload. Nitroglycerin would aggravate the situation and cause hypotension, and therefore could even lead to death. So, when you diagnose an inferior wall MI, always check for the presence of right ventricular infarction. So, how do we diagnose right ventricular infarction? Well, look at the ST segment elevation. And if the ST segment elevation is going to be more in lead 3 compared to lead 2, then that means to say that you have a right ventricular infarction. So in order to drive that, let me just proceed right over here and show you an electrocardiogram, a 12-lead ECG with a right ventricular infarction. So let's try to analyze. What do you see in lead 1? As far as the ST segment is concerned. Normal, depressed, or elevated? Depressed. Okay, so we have depressed. How about lead 2? Lead 2 is elevated. And how about lead 3? So, do we have an inferior wall MI without even going further? Yes, we do, because lead 2 and 3 are contiguous leads, right? So now let's take a look at the ST segment elevation of 2 and lead 3. Which one is elevated more? Is it lead 2 or lead 3? Lead 3 is elevated more. And therefore, as we said, if lead 3 is going to be greater than lead 2 right over here, then that means to say that we have a right ventricular infarction. Okay. So for those of you who work in the emergency room, whenever we have an inferior wall MI, we actually also do a right-sided 12-lead ECG. And that means to say that instead of applying the leads towards the left on the precordial leads, we also do it on the right. And as you could see over here, this is exactly, my pointer is lost. Oh, hold on. Okay, as you could see right over here, there is a V4R. That means to say that this is lead V4 on the right side of the chest. Okay, so they added an additional lead in order to show you the ST elevation in that particular area of the chest. All right, is there any question on right ventricular infarction? So we have thus far talked about inferior wall MI and right ventricular wall MI. Are there any questions as far as those two types of MI are concerned? No questions? All right. In that case, let's go ahead with the anterior wall MI. Anterior wall infarction rarely presents by itself. As I had indicated earlier, it commonly occurs with infarcts of the septum or the lateral wall or both. However, the leads that represent the anterior wall are V3 and V4. So please write that down in your notes. For the anterior wall, it's V3 and V4. When both the anterior wall and the septum are affected, the infarct changes will show from V1 to V4. But if it's just V3 and V4, then this is just the anterior wall. V1 and V2 represents the septal portion of the heart. V5 and V6, as well as lead 1 and AVL, represents the lateral wall. Okay, so why are we talking about all these areas whenever, I thought we were just talking about the anterior wall. Well, the reason I'm saying is that whenever you have an anterior wall MI right here, because it's so proximate to the lateral portion as well as the septal portion, you might have a combination of both. Excuse me, let me just take a drink. Okay, so the anterior wall is represented by V3 and V4, the lateral 1 AVL, V5 and V6, and the septal, I should say, V1 and V2. So let's take an example of a 12-lead ECG over here. This is an example of an anterior wall MI. Which of these leads are elevated? Which leads are elevated? Okay, it's already indicated over here. We have ST elevation in V2, in V3, V4, V5, and none in V6. So V1 is elevated, but not elevated, but V2 is. Now we can therefore not diagnose septal wall MI. Okay, because in order to diagnose septal wall MI, you must have the presence of ST elevation in V1 and V2. However, since you have ST elevation in V3 and V4, can you diagnose anterior wall MI? Yes. Now we have ST elevation in V5, but not in V6. Can we diagnose lateral wall MI? No. Okay. So this is just an example of an anterior wall MI. Let's take a look at lateral wall MI. Lateral wall MIs can occur by themselves by showing changes in lead 1, AVL, V5, and V6, or they can occur in combination with other infarct patterns. The lateral wall, as I had mentioned earlier, is supplied by the circumflex coronary artery. It could also be supplied by the left anterior, LAD, or the left anterior descending coronary artery, or sometimes it might even be a branch of the right coronary artery. But majority of the time, it's going to be a feeder from the circumflex coronary artery that is going to be the culprit. And so let's take a look at the 12-lead ECG representing the lateral wall MI. Okay, so if you're taking a look at this, what is lead 1? Okay, so this is elevated. And how about lead 2? Depressed, very good. And how about lead 3? Depressed, very good. How about AVL? Elevated. And how about AVF? Depressed. V1? Depressed, very good. How about V2? V2? V2, some of you are saying elevated. This is V2 right here. It's depressed. How about V3? Depressed. And V4? Okay, might be, I don't know if it's elevated or not. So how about V5? This is the ST, so it's elevated, isn't it? And how about V6? So we don't know either. Okay. But there's ST segment elevation in 1 and AVL. Are these two relatives? Are these two relatives? Yes. So therefore, we can diagnose a lateral wall MI. Okay. So let's now go to some 12 ECG prints and see if we could diagnose them. Okay. So here's the first one, and I'd like for you to examine them and then come up with a diagnosis. Okay, so it looks like 88% of you diagnose it as being an inferior wall MI. Some of you said that there was anterior. Some of you said high lateral. Some of you said septal. And some of you said that there's right ventricular infarction. So let's see what The correct answer is lead 1 is depressed, correct? All right. So lead 1 is depressed. How about lead 2? It's lead 2 is elevated. And lead 3 is elevated. And we also have a presence of a higher ST elevation in lead 3, isn't it? Okay. And how about AVL? AVL is depressed and AVF is elevated. So immediately we all know that there is an inferior wall MI. So for those of you who answered inferior wall MI, then it is correct. At the same time, there is presence of a right ventricular infarction. And the reason why there is right ventricular infarction is because lead 3's ST elevation is greater than lead 2. Now, if we look at V1, it appears normal. V2 appears depressed. V3 is normal. V4, we don't know because it's not seen at all. V5 and V6. So the diagnosis and the correct answer here is we have an inferior wall MI as well as we have a right ventricular infarction. Question. So this patient is having severe chest pain because they're having a myocardial infarction. May we give nitroglycerin to this patient to relieve the pain? Okay, so remember that anything that decreases the preload or any vasodilator on the venous side is going to be contraindicated. So be very wary. If you have an inferior wall MI patient and they have chest pain, obviously you're not going to include nitroglycerin as part of your intervention. Okay, let's go to the second exercise. Wow, everybody is very good. I mean, all excellent. Okay, this is how you responded. A lot of you answered anterior and septal, with some saying that it might be inferior and also lateral and right ventricular. So let's go ahead and discuss. Now we have ST depression in lead 1, right? Or normal, maybe, I don't know. It is borderline. So let's go ahead and say that it is normal. How about lead 2? It is depressed. Lead 3 is depressed. AVL is normal. AVF is normal. V1, however, is elevated. V2 is elevated. V3 is elevated. V4 is elevated. And V5 is normal. And V6 is normal. So ST elevations in V1 and V2, because they're related, this is diagnostic of a septal wall MI. And V3 and V4 is diagnostic of an anterior wall MI. So we both have a septal wall as well as an anterior wall MI. Okay, pat yourself on the back if you got it. For those of you who did not get it, that's okay. Be patient with yourself, particularly if you are new to 12-lead ECG. It's okay because you're still learning. Let's go to the next one. Okay, this is how each one of you responded. A lot of you said that it was septal wall MI, as well as an anterior, lateral, and some of you said inferior and right ventricle. Okay, so we can eliminate right ventricular infarction because if you do not have any ST elevations in 2, 3, and AVF, you cannot have a right ventricular infarction. Okay. All right. So let's take a look. Lead 1. What is lead 1? It's elevated, isn't it? And lead 2 is right over here. Maybe, I don't know. Lead 3 is depressed. AVL is elevated and AVF is depressed. V1 appears normal, isn't it? And how about lead 2? V2, I'm sorry. V2 is elevated. And V3 is also elevated. V4 is also elevated. V5 is elevated. And V6 is elevated. All right. Is somebody confused, or does somebody have any question about how we diagnose these to be elevated or depressed before we go any further? Okay. So if we have ST elevation in 1 and AVL, what view is this? They're related, and this is lateral. Okay. We also have a ST elevation in V3 and V4. These are related. These are the anterior aspect of the left ventricle. So we have an anterior lateral wall so far. And V5 and V6 are also related. They look at the lower lateral portion of the heart. And therefore, we have an anterolateral wall MI. Okay. Let me just erase all ink and go forward. Okay, remember that in order to have a right ventricular wall MI, you should have an inferior wall MI as well. Okay, there's no ST elevations in 2, 3, or AVF. So therefore, we could remove right ventricular. Okay, let's end the poll. And this is how you responded. And so let's go ahead and discuss. Lead one. What do you see about lead one? Lead one is elevated, isn't it? Okay, so we can say this is elevated. Lead two is depressed. Lead three is depressed. AVL is elevated. How elevated? Because over here, as you could see, that's the baseline, and AVF is depressed. All right, V1 is elevated. V2 is elevated. V3 is elevated. And V4 is also elevated. V5, no. And V6 is no either. It's normal. So the ST elevation is lead one and AVL. These are relatives. This is the lateral wall. V1 and V2 are elevated. These are relatives. This is the septal wall. And V3 and V4 are elevated, and they're relatives as well. And therefore, this is going to represent the anterior portion of the left ventricle. Therefore, what do we have? We have an anterior wall and septal wall as well as a lateral wall MI. This patient is sick, very sick, because this is what we call a massive MI. There are different segments of the heart that are involved. Are there any questions about this particular 12 lead before we go to the next one? Okay. All right, here's the next one. All right. The confusion might be that, let's see. Let me just write something up over here. Okay. So inferior wall MI is going to be changes in either leads 2, 3, and AVF. And we always have to consider that right ventricular wall MI might be present if there is an inferior wall MI. And lead 3 is going to be greater than lead 2. Okay. If that is the case. Anterior is going to be ST segment elevation in V3 and V4. Septal is going to be ST elevation in V1 and V2. And lateral infarction is going to be either lead 1, AVL, V5, and V6, okay? So if you would just keep this for many, many years, when I started in electrocardiography, I wrote this in a piece of paper and kept it on my wallet to make sure that I don't forget it. So you can put it in your phone now in order to refer to it whenever it's necessary, okay? So these are the things that you need to remember, unfortunately. And so the thing that, the correct answer here is, let's look at the results first of all. And let's take a look at what the correct response is. Okay, the ST elevations are present in lead 2 and lead 3, as well as in AVF. So immediately, because we have ST elevations in 2, 3, and AVF, we have an inferior wall MI. And we said, anytime that there is an inferior wall MI, we must always consider the possibility that right ventricular infarction has also occurred. And so
Malalakon.
hold on. That's great.
Ne, mangmangang ka, ano niya?
All right, I muted them again. All right, so now we could see that there is, I lost my train of thought. We have an inferior wall MI, and whenever we have an inferior wall MI, because it's an obstruction of the right coronary artery, we also think of the right ventricle. And there is a right ventricular wall MI if lead 3's ST elevation is greater than lead 2, which it is in here. So the correct answer is we have an inferior wall MI as well as a right ventricular wall MI. And the reason why it's important to diagnose the presence of right ventricular wall MI is the fact that in right ventricular wall MI, nitroglycerin is contraindicated. Okay? All right. So let's move on to the next one. This one. Okay, this is how you responded. Okay, so just take a look at how you responded and let's see and discuss. Lead 1 is going to be normal. Do you agree? And lead 2 is elevated, and I'm going to zoom it in to see its ST segment elevation of 1 millimeter. So you remember that in the limb leads, an ST elevation of 1 millimeter is going to be significant. And lead 3 is also elevated by 1 millimeter. So over here, we now can diagnose because there's also ST elevation in AVF. We can diagnose the presence of an inferior wall MI. So those of you, 82% of you said that there is an inferior wall MI. You are indeed correct. Okay. So AVL is, my pen is not moving. AVL is depressed. V1 appears normal, and V2 appears normal as well. V3 appears normal. Now, why am I saying that V2 and V3 is normal? You remember that the criteria for a significant ST elevation in the V leads is how many millimeters? How many millimeters should it be elevated in the V leads in order to be significant? 2 millimeters, okay? So in here, we only have a 1 millimeter ST segment elevation. Therefore, we could not claim that this is a significant ST elevation. The same thing in V4, V5, and V6. So all these, although they appear to have an ST elevation, you remember you forgot, I should say, that it has to be 2 millimeters in order to be significant. All right. So that's the reason why the correct answer here is an inferior wall MI. There appears to be no right ventricular infarction. And the reason I say that is the ST segment in lead 2 and lead 3 appear to be the same. It's not very significantly more elevated in lead 3. Okay? Now, if we are going to do another 12-lead ECG in another 30 minutes, who knows? Maybe there's going to be a right ventricular infarction as well as infarction in the lateral leads. So that's the reason why we always repeat ECG as a series. We don't rely on just one ECG. We might do it in the next 30 minutes or next hour or so in order to determine the progression of the myocardial infarction. And I think we're almost towards the end. So let's take a look over here. Okay. So 11 of you have responded. I'm waiting for the rest. All right. More of you need to respond. There's only 13 out of 44. Okay, let's take a look at lead one. Lead one appears to be normal. Lead two appears to be elevated. Lead three is elevated. AVL is depressed and AVF is elevated. So we have elevations in lead two, lead three, and AVF so far. Okay. So we have an inferior wall MI. So for those of you who answered inferior wall MI, you're absolutely correct. Now, because it's an inferior wall MI, we have to evaluate it for the presence of a right ventricular infarction. So let's zoom this in to see the height of the ST segment elevation. In lead two, we have two boxes. And in lead three, we have 1, 2, 3. So lead three is higher in ST elevation than lead two. And therefore, we also have a right ventricular infarction. Okay. V1 appears to be normal. V2 appears to be normal as well. V3 appears to be normal as well. Again, I'm saying normal because the ST elevation is not going to be, what do you call that? Is not going to be significant. V4 is elevated, and I think it might be significant. V5 is elevated as well, and V6 is also elevated. So let's see. So V3 is normal. V4 is elevated. However, it doesn't have a partner. V5 is also elevated. And V6 is elevated but not significant. So therefore, it's not going to be a significant ST elevation in V5 and V6. So the correct answer is an inferior wall MI with a right ventricular infarction. Okay. And this is the last one before we go to our quiz.
Bangad ni Uno.
Okay, lead one. What do you notice about lead one? It is depressed, isn't it? Okay, so let's see. So lead one is depressed. And how about lead two? It's elevated. And lead three is elevated. AVL is depressed. and AVF is elevated. And V1 is slightly elevated, but it's not significant. It's only 1 millimeter. V2 is normal. V3 is elevated. And V4 is not elevated. Okay, so it's normal. And V5 is normal. And V6 is normal. So we only have leads 2, 3, and AVF as elevated. So we have an inferior wall MI. And again, whenever we have an inferior wall MI, we have to evaluate for the presence of a right ventricular infarction. And therefore, you're going to have in here, a greater ST segment elevation in lead 3 than it is in lead 2. Thus, we have a right ventricular wall infarction. So a lot of you answered that correctly, the inferior wall, as well as the right ventricular wall MI. And therefore, this is the correct answer here is that there is a right ventricular wall MI as well as an inferior wall MI. Okay, so we're now going to go to an evaluation of how you did. And this is just to evaluate yourselves on your understanding of the material that we had learned today. And we're going to do that by doing a game called Kahoot. And the Kahoot game is going to be something that will help you determine your understanding of the material. So some of you are familiar with this, but for those of you who are not familiar, please open a browser on your phone or your computer and type www.kahoot.it, not .com, .it. Follow the instructions by entering the code that appears on the screen and type your name for this game. And questions will appear on the screen and your device will show color-coded response menu. You will answer on your device by choosing the appropriate color, and note that the questions appear only on the screen, on the Zoom screen. The object is for you to respond correctly and quickly, and you win by demonstrating accuracy and speed. All right? For your prize for winning, you're going to get a visa today. I'm kidding. I wish I could do that. Okay? So let's go ahead and play the game. Okay. And we're going to... All right, get ready to join. Okay, if you go to kahoot.it and enter the pin 704-4466. Okay, for those of you who are not able to join for some reason or another, you still could remain online and see how this game is done. You still could learn from the questions. Okay, so if you log in while we're playing, the game pin will appear still at the bottom of the screen. So let's start. Okay, so the question was, which of the following is not an ECG marker of MI? We all know that myocardial infarction could be diagnosed in the electrocardiogram by the presence of an ST segment elevation. You could also diagnose it based on the presence of inverted T waves as well as abnormal Q waves. And I must also add a new left bundle branch block. So all those, but PR's intervals are not going to be helpful in the diagnosis of a myocardial infarction or SEMI. So therefore, the correct response over here is prolonged PR intervals. So let's see. Who was the fastest? Eileen is the fastest, Nicole, Keenus, Dixon, and Joe. Congratulations for them. Okay, so let's see. The J point is letter C. Remember now that the J point is important in the sense that this is the beginning point of the ST segment. And therefore, this is the one that we're evaluating whenever we're looking at a 12-lead ECG for the presence of myocardial infarction. So let's see who got that correctly. Eileen, Keenus, Nyayemi, Eileen, Nicole, and Dixon. Congratulations to all of you. Okay, so the correct answer is an ST segment elevation of 1 millimeter in the limb leads or 2 millimeters in the V leads are going to be significant and diagnostic of STEMI. And so let's see who answered the fastest. Nicole again, Dixon, Terry Ann, Keenus, and Yayemi. Congratulations to all of you. All right. Most of you got that correctly. That is the standardization mark. And the fastest one, again, was Nicole, Dixon, Terry, and Eileen, and Yayemi. Okay, so the 2-3 and AVF, which is the inferior aspect of the heart, is supplied mainly by the right coronary artery, and therefore that is the correct response. So let's see who answered it the fastest again. Nicole, Dixon, Terry, and Eileen, and Kines. And congratulations. Okay, so a lot of you responded that this is an inferior wall MI. So let's see, the ST elevations are in 2, in lead 3, and in AVF. And that's where all the ST segment elevations that are significant are located. And therefore, this is an inferior wall MI. Great. So a lot of you got that correctly. And so let's see who was the fastest. Nicole, Dixon, Eileen, Kines, and Terry Ann. Congratulations. Okay, so we have ST elevations in leads 2, 3, and AVF. With lead 3's ST elevation more significantly more than lead 2. So we have an inferior wall MI and a right ventricular wall involvement. We also, in addition to that, ST elevations in V1 and V2 and V3. So V1 and V2 can be also significant in the sense that they represent the septal wall. So the correct answer is 3 areas of the heart or segments of the heart: inferior wall, right ventricular wall, as well as the septal wall. And a lot of you got that correctly. That's great. And again, Nicole, Dixon, they are our ECG experts, and Eileen. Congratulations. Kines and Yayemi. Excellent. Okay, a lot of you got this correctly. 1 and AVL obviously are the ones that look at the lateral portion, the high lateral portion of the heart. And so Nicole, Dixon, Eileen, Nicole, Kines, and Yayemi again are the fastest. Congratulations. Okay, we have a variation of responses over here. So let's see. Some of you said inferior wall MI, which is correct. We have 2, 3, and AVF. But in addition to that, as we have recalled, you must always evaluate for right ventricular infarction when you have an inferior wall MI. And in fact, we do have a right ventricular wall MI because lead 3's ST elevation is greater than lead 2. So the correct response is inferior wall MI and right ventricular wall MI. Okay. We do not have a lateral extension of the MI because we do not have ST elevation in one AVL, V5, or V6. Okay, so let's see. Dixon, congratulations. Eileen, congratulations. Nicole, Keenus, and Joe. Okay, a lot of you seem to have gotten this well. We have ST elevations in V1, V2, V3, and V4. So these represents the anteroseptal wall of the heart. And so the correct answer is blue anteroseptal wall. And let's see. Eileen, the expert, Dixon, the expert, Nicole, the expert, Joe, the expert, and Keenus, the expert. Congratulations. Okay, we have an equal distribution of all the options except for the lateral wall. So let's see. We have ST elevation in the lead 1 and AVL. This is lateral wall. So we have to include that in our diagnosis. It's a high lateral wall. And we also have ST elevation in V2, V3, and V4. So V3 and V4 looks at the anterior portion of the heart. V5 and V6 also. So the whole lateral wall. We cannot claim a septal wall MI because V1 is normal. Okay, so the correct response, therefore, is that we have anterolateral wall MI. Anterolateral wall MI. And so let's see who got that correctly. And as usual, our resident expert, Eileen and Dixon, Nicole, Joe has the highest streak, and Nyayemi. Congratulations. Okay, we have a anteroseptal wall MI. Let's see why that is. We have ST elevation in lead 1, V1, I should say V2, V3 and V4. So this is the anteroseptal portion of the heart. But we also have an ST elevation in 1 and AVL. So there has got to be anteroseptal wall and lateral wall MI, which is not in here. So for those of you who answered the anteroseptal wall MI and anterolateral wall MI, you're both correct, okay? But nonetheless, let's see who was the fastest. Eileen again, and Nicole is back in the game. Joe, Dixon, and Kines. Congratulations. Okay, we have an inferior wall MI with a right ventricular wall MI. The reason is we have ST elevation in lead 2, lead 3, and AVF. And the elevation in lead 3 is significantly higher than lead 2, and therefore it points to a presence of a right ventricular MI. Eileen, Dixon, Nicole, Joe, and Kines are the leads. And all these people can now teach 12-lead ECG for the identification of STEMI because they seem to be experts. Congratulations. Okay, so if we were to look at this, there is an inferior wall MI because there's ST elevation in 2, 3, and AVF. The other name for inferior wall MI is diaphragmatic wall MI. And in addition to the presence of the inferior wall MI, we have a right ventricular MI as well. Okay, so let's see. Eileen, Nicole, Dixon, Kines has the highest answer streak, and Joe, congratulations. And the last one. Okay, everybody seemed to have gotten that. And so let's see who the honor rolls are. And number 3 is Dixon. Congratulations, Dixon. And number 2 is Nicole. And number 1 is, let's see, Eileen. Congratulations. And runners up are Kines and Joe. Congratulations. Okay, so what I'd like to do now is to say that it has been my pleasure to be with you this morning on my end. And I hope that you had learned something about 12-lead ECG. I look forward to seeing you again in the future. I'm going to stay online for the next 30 minutes to answer any questions that I might have failed to respond to, or if you have any questions remaining. I look forward to seeing you in the next webinar next week on Monday. And I thank you again for your participation. That ends our webinar for today. Thank you.